Welcome. Today we shall be looking at jaundice. In this presentation, we will look at the causes, classification, clinical presentation, the diagnosis and management of jaundice. Jaundice is defined as an abnormal yellowing of the skin or the sclera that is caused by an accumulation of bilirubin. It becomes clinically visible when the serum bilirubin levels exceed 2 to 2.5 mg per deciliter. Hyperbilirubinemia is caused by either an increase in bilirubin production or a decrease in hepatic uptake, conjugation, or excretion of bilirubin. When looking at bilirubin metabolism, bilirubin component is produced from a breakdown of heme component in the aged red blood cells. Initially, it is unconjugated and bound to albumin in plasma. In the liver, it undergoes conjugation by UDP glucuronide transferase, becoming water-soluble. The conjugated bilirubin is then excreted in bile into the intestines, where it's converted into urobilinogen and eliminated through stool and urine. Jaundice can be classified into three types: pre-hepatic jaundice, the hepatic jaundice, and post-hepatic jaundice. Pre-hepatic jaundice occurs pre-hepatic jaundice occurs due to increased bilirubin production, like in the cases of hemolysis. Hepatic jaundice occurs due to impaired processing of bilirubin that is seen in patients with hepatitis or liver injury. And lastly, a post-hepatic jaundice, also known as obstructive jaundice, occurs due to a blockage of bile flow, commonly from gallstones or tumors. Let's break down these types of jaundice. Pre-hepatic jaundice arises from an increase in red blood cell breakdown, producing excessive unconjugated bilirubin. The liver's capacity to conjugate bilirubin is therefore overwhelmed, and the causes for this pre-hepatic jaundice include hemolytic anemias, sickle cell disease, malarias, and transfusion reactions. The next type of jaundice is hepatic jaundice. Hepatic jaundice occurs due to liver cell dysfunction, impairing bilirubin conjugation or excretion. The common causes of hepatic jaundice include virohepatitis, alcoholic liver disease, drug-induced hepatotoxicity, and genetic disorders such as Gilbert's and Crigler-Najjar syndrome. Lastly, post-hepatic or obstructive jaundice results from mechanical blockage of the bile flow. Conjugated bilirubin cannot be excreted and it's regurgitated back into the bloodstream, and the causes for post-hepatic jaundice include gallstones, cholangiocarcinomas, pancreatic head tumors, and strictures of the bile ducts. There's another type of jaundice known as neonatal jaundice. A neonatal jaundice is quite common, especially in premature infants, and is often classified into physiologic or pathological jaundice. Physiologic jaundice occurs due to an immature hepatic enzymes, and pathological jaundice, on the other hand, arises from hemolysis or infection and poses greater risk for kernicterus. And on the other hand, pathologic jaundice occurs due to a hemolysis or infection, posing a greater risk for kernicterus, which is a form of bilirubin-induced brain damage. The classical features of jaundice include yellowing of the sclera and the skin, dark-colored urine in conjugated hyperbilirubinemias, and a pale stools due to lack of stacobilin. Some patients experience pruritus, fatigue, and right upper quadrant pain, depending on the cause. The important clinical signs that we find in jaundice are Courvoisier sign and Murphy sign. The Courvoisier sign is a palpable, non-tender gallbladder in jaundice patients, suggesting malignancy rather than gallstones. And in Murphy sign, there's pain on palpation on the right upper quadrant, suggesting of acute cholecystitis. Asterixis or flapping tremors may be present in hepatic encephalopathy patients. When looking at investigations, Laboratory tests for jaundice include a liver function test to assess for total and direct bilirubin, an LT and AST for hepatocellular injuries, LP and GTT for cholestasis, complete blood count, including a reticulocyte count, prothrombin time, and international normalized ratios, the albumin levels as well. An imaging test including ultrasound is the first-line imaging modality for assessing biliary tree and detecting gallstones. A CT scan or an MRI can be used to detect tumors or liver architecture abnormalities, and MRCP and ERCP can be both diagnostic and therapeutic. Some special tests, depending on the case, include hepatitis serology, autoimmune markers, and genetic testing for Crigler-Najjar syndrome and Gilbert's syndrome. The management of jaundice depends on the cause, whereby a pre-hepatic jaundice requires treatment of the underlying hemolytic condition. An hepatic jaundice management involves antiviral use in case of viral causes, corticosteroid use, and supportive care. For post-hepatic jaundice, the management requires ERCP, stent placement, or surgery to relieve the obstruction. The treatment of neonatal jaundice includes phototherapy, which converts bilirubin to water-soluble form that is excreted in urine. Severe cases may need an exchange transfusion to prevent the development of kernicterus. Uncontrolled jaundice may lead to kernicterus in neonates, hepatic encephalopathy, vitamin K deficiency causing coagulopathies, or a progression to chronic liver disease with portal hypertension.